Everyone. So hello and welcome to the Harvard Center for International Development Fridays Speaker Series. I am Carla Estrella. I am a student here at Harvard Kennedy School doing a Master's in International Development, and I am a CID Student Ambassador. Here at CID, our mission is to build a thriving world for all. We work across the university and a global network of researchers and practitioners to build an international pool of talent, convene academic and practitioner networks, and deploy breakthrough research to address the world's most pressing challenges. This is why we're so excited about today's conversation on public health programs and development assistance. Before we start, I want to mention a few housekeeping items. First, please enjoy lunch, but help us help the planet by doing your part. All food items, including cups and napkins, are compostable. Second, please hold your questions until the speaker has finished the presentation and has opened the Q&A section. At the time, I will go around with a microphone so we can all hear you clearly. We are recording today's session, but we will keep the camera on the speaker to ensure that only voices from the audience will be recorded. The video of this event will be available at the CID YouTube channel afterwards. A CID team member may take photos of the event for use on CID's social media channels. If you're not comfortable with your photo being used this way, please let a CID member know. Please use the QR codes located around the room to check into today's event. This helps the CID team track attendance and organize food for future events. Finally, please make sure to subscribe to CID's newsletter and follow Harvard CID on LinkedIn and Instagram to learn more about our events and stay connected to the CID community. Now, I would like to briefly introduce our speaker for today. I'm sorry if I mispronounce, but it's Lia Tadesse Gebremedhin, the former Minister of Health of Ethiopia. Lia is the Executive Director of the Harvard Ministerial Leadership Program and a visiting faculty member at Harvard T.H. Chan School of Public Health. Previously, she served as Ethiopia's Minister of Health from 2020 to 2024, guiding the country's COVID response. She also held roles as Program Director at the University of Michigan Center for International Reproductive Health Training, Project Director of USAID's MCSP at Japiago, Ethiopia, and CEO Vice Provost of St. Paul's Hospital Millennium Medical College. Lia is known for her passion for health system reform and recognized for her efforts in pandemic management, gender equity, and healthcare quality. She holds leadership and advisory roles with organizations like COVAX, GFF, Africa CDC, Gavi, WHO, JSI, and Resolve the Save Lives. She earned her medical degree and specialty training in obstetrics and gynecology from Ethiopian universities and a master's degree in healthcare administration from Jimma University. Thank you all for being here, and Lia, over to you.
Thank you so much, Carla, for the kind introduction, and good afternoon, everyone. It's a pleasure to be here today for this speaker series on a very important and timely topic, I believe. I am generally an optimistic person and determined to keep my optimism, but we can all agree this is a very challenging time for many countries across the world. And when we think of development assistance or financing in general, the current status that we are in globally, particularly for lower and lower middle income countries, is when we are seeing the highest rates of related to debt challenge and debt servicing costs being really high, with the interest rates being high, and when countries are very challenged to invest in key development areas like health and education. And unfortunately, those who are affected most by this challenge of having to pay high debt servicing costs and high interest rates are those countries which have the highest needs for development and limited fiscal space. So while we have this on the one hand, the issues of development assistance, which plays a crucial role in the progress and development of countries towards sustainable development, is a time when it's very significantly challenged. Of course, the current new change based on the new US administration has really magnified it, but this has been ongoing globally. In general, the international development assistance has been declining. So in that context, what I'll be talking about today is the experience of Ethiopia in how we were dealing with development assistance for health, particularly with the aim of sustainable financing, and how, in general, the development assistance was managed, but also the key aspect of domestic financing and other initiatives that are meant to have sustainable transitions. So I'll be mostly focusing in sharing that experience from Ethiopia, particularly from my role as a Minister of Health and Deputy Minister for about 6 years. So just a brief background of Ethiopia. It's a country located in the northeastern part, commonly known as the Horn of Africa, where we've estimated around 120 million population. Our last census was a bit outdated, but that's the estimate now, with the GDP, as we can see, and grows about 6.5 growth rate, diverse topography, diverse cultures, which makes many of our development work challenging. It's a very young country, as many African countries, with a median age of 19, and children accounting for less than 5 years, accounting for about 15%. So in the commitment for universal health coverage is the key driver for the whole strategy as a country. And this, when we say universal health coverage, is a situation in which all individuals and communities receive the health services they need without suffering from financial hardship. And Ethiopia is explicitly stating this commitment to UHC and driving the implementation towards UHC through different strategies, like primarily focused on primary healthcare, but also expanding access to healthcare, but also in initiatives like health insurance, which I will address a little later on. So when we are talking about universal health coverage, the key determinant for progress towards UHC is the size of resources available. And that is composed of different resources, government being the key player, but also out-of-pocket expenditure from communities, donor or development assistance, private, and others like insurance. And in 2001, heads of states of African countries made a commitment of called the Abuja Declaration, that they should allocate 15% of the budget to health. But unfortunately, there is progress, but most countries are still allocating much lower, which is less than 8%. So in Ethiopia, the expenditure for health, the total expenditure for health, which includes both government, public, and development assistance, all sources combined, is continuously increasing, which is in the positive trend, but it's still now currently around 8.4%. But it's the encouraging part is that there's a continuous increasing trend, which is not similar to the global trend, which unfortunately shows a decline from where we were in 2000 versus where we are in 2021, based on the Lancet Commission's recent report on global health 2050. So the current, the most recent data that we have is that we have per year, it's about 3.6 billion USD, which for such a big country, you can imagine it's a very small amount. And the per capita expenditure has increased from 28 to 36 in the last, from 2018 to 2022, but still very far from WHO's recommendation of $86 for countries like Ethiopia. This is just to show the trend of the total expenditure, which I just mentioned, around 3.6 now, but you can see the continuous increase in trade. The last two is the same years, but it's just showing COVID and then excluding COVID because that had an impact on the increase. When we look based on sources of financing, so these are the different colors. I don't know, because you may not see the indicators up, but the green one is showing the household or out-of-pocket expenditure. The darker blue one is showing government source, and then the lighter blue one is showing donor funding. There are a few small ones. The red is insurance and other private showing private sources showing the yellow one. So you can see the government resource at some point had declined and now is increasing to about 32%. And donor financing, especially in the earlier parts of the Millennium Development Goals and up to 2010, it had even gone up to 50% of the source that the country depended upon, but continuously had declined, with the government taking more share, which is encouraging, but still you can see 33%, around 34%, which is still high. And then the out-of-pocket expenditure, although some progress, but not so much, is, as you can see, around 30%. The WHO recommendation to ensure that access is access without financial hardship should not be more than 15 to 20%. There is some financing now, as you can see, the private sector insurance, but it's very low, but there is some increase, which is in the right direction. This is just to show at sub-Saharan Africa level, the spending sources, which I just showed for Ethiopia. This is from the Institute of Health Metric and Evaluation, which shows for the large part, you can see that actually the government expenditure again has increased in the right direction, but this is showing the total. When you look at the percentage, it's still there's high dependency of development assistance, but also more concerning is that there's still very high out-of-pocket expenditure in many countries. This is just to show some countries, the top 30 populous countries ranked by out-of-pocket expenditure. This is from the recent Lancet Commission report on 2050 on reducing premature mortality, showing that in some countries you can see that the domestic, the government expenditure is significantly increasing in the right direction, but in some countries you can see the out-of-pocket payment even reaches up to 80%, which is very concerning. So, what were the strategies that we have been using in terms of sustainable health financing in all this ecosystem? So one, particularly as it relates to development assistance, which as I said, plays a key role in all the progress we have made. One is to ensure that there is strong country leadership and governance in terms of how development assistance is spent and how we are working in collaboration. So the first is to make sure that we have one national vision and strategy that's owned by all stakeholders, but led by the government. So when we are developing the 5-year or 3-year or 10-year strategies, it is through engaging all the key stakeholders from community up to all the partners, so that this is a joint plan or owned. And then, of course, it's not enough to have a plan, but you need to have key approach to make sure that we are aligned across that one plan. But the principle we follow is the issue of one plan, one budget, one report. But to have this in practice, then the first is that there are government-led coordination platforms that are set up. So regular meetings that are co-chaired by the minister and designated rotating co-chairs from the donors. Review, we have what we call joint consultative forum at a leadership level and then at a technical level. But we are guided also by joint financing agreements, which clearly states that we are going to invest those all the resources on the national plan and how we monitor jointly. So like a commitment between the government and donors on how we are implementing. The other key aspect is how finance is channeled for implementation. So there are, in general, 3 channels that we call. The first one is this the global budget that comes through government, that donors would provide to governments through ministries of finance, and this would be allocated as per the national budget combined with treasury budget. So that's considered as a government budget. And then channel 2, we have different approaches. There are some vertical programs which directly fund the ministry, like the Global Fund, Gavi, which give the ministry to implement those specific programs on HIV, malaria, TB, and others. And then within the channel 2, there is a very good experience of Ethiopia of establishing a pooled fund where it's not specific for vertical programs, but different donors would put in their money in that basket to implement the national priority. So we started as an MDG pool fund in 2008 and then became SDG pool fund. So we have around 12 donors and continuously working with different donors to channel their funds towards this pool fund for maximizing impact. And this, the third one, the channel 3, is where donors would give their finances or resource grants to implementing partners, either international NGOs or local NGOs, or in some cases private sector, to implement those interventions. But even for those in channel 3, what we call channel 3, through other implementers, we ensure there is a key process of alignment towards the national priorities. So every year in the planning process, we undergo alignment with all the other partners, although it's not always easy, but to ensure not that we don't have duplication of efforts, also that we don't have geographic duplication, but also that the interventions are actually aligned with the national plan. So the fact that we are doing this channeling, particularly what I said, channel 2, where we have the pool funds, or even if it's directly funded as a vertical program, it has multiple benefits. One, it strengthens government systems, our financing, our procurement systems, so that when these systems, when these kinds of even support is not there through our own financial system, is much stronger. And the other is there is a lot of efficiency gain in terms of pooled like the pool procurement or other, because there's a lot of expenditure, administrative expenditures when it's implemented through partners. But of course, there is a place where there should be such kinds of support. It doesn't mean that all of the resources should only go through government, but significant going towards government has always been the approach we try to work with the development partners. And the other key aspect towards sustainable health financing is where and how we invest those resources. So of course, there are vertical programs where we still invest in terms of addressing HIV, malaria, TB. But in each of those, in all of those programs, be it the vertical programs or others, we ensure that there is health system strengthening approach so that those investment can actually be lasting. If you are only providing it through temporary methods of where they are being financed by other partners, and when those programs are stopped, usually there is backsliding. But ensuring that there is investment on infrastructure, on equipment, on health workforce development has been a key approach. And one, I think one of the main strengths for us is that the health workforce primarily is only funded by government to ensure that there is sustainability. So even for programs like the Global Fund, which are specifically focused on things like HIV, malaria, and tuberculosis, we also use some of the funds in collaboration with our partners to expand the infrastructure of health centers, because you need the facilities to provide the care, strengthening the National Pharmaceutical Supply Agency with partners like USAID and Gavi. And even within the pandemic response, when resources were mobilized for the COVID response, we were trying to make sure that we made, again, investments like capacity in oxygen access, ICU, through funds like the World Bank and others. And the other, as part of the health system strengthening, is also the financial, the health financial system itself. So ensuring that there is public financial management capacity is enhanced, because one of those, the challenge that many countries face is that their public financial management system is not strong, and that's why donors usually try to use other mechanisms to implement projects rather than using government. So this is one key area, including accountability, both at a national and subnational level, and recently also the use of digitization to ensure that this is progressing, because that's one of the key challenges, and also having transparent communications. Of course, this always requires a lot of negotiation with development partners to ensure that this is the approach that we take. This is just to highlight that you can see when you look at health focus areas from for development assistance in health, majority of them are on specific diseases or vertical programs. So the health system specific ones are very limited. The light blue one you see on the top one is where you have health system strengthening. All the others are mostly specific disease programs. And you can even see that the NCD, which is now really a big pressing problem, which is the pink one, is still just coming up now, which is very small, and hopefully this would have a different kind of spectrum in the years to come. The other one in terms of sustainable health financing is the implementation of national health insurance. So Ethiopia started the piloting of community-based health insurance in 2013, and then expanded in the different subnational regions and districts. So by now, by last year, we have around 1,009. This is about close to 85% of the districts, benefiting 55 million people. And this is, which is a mechanism where they would pay a small premium to cover their whole families. And for those indigent or designated as indigenous population, the government pays that premium. So with some of the studies that were done, it shows those insured households versus not insured one, the healthcare utilization increased by 2.6 times, because we have very low utilization rate, and reduced per capita health expenditure by 15 to 14% points. And also the families were able to increase expenditure to other non-health issues like non-food or food items compared to non-insured. So this is showing encouraging progress, and it also has contributed to the overall health revenue, although it's yet still relatively small. So there is a lot of efforts now to ensure the whole system is strengthened with a stronger pooling, so that it can continue to grow. And also the implementation of the formal sector is also underway, because this is only for the informal sector, which is the largest share of the population. But there are also other innovative initiatives that are underway to enhance domestic financing, because when we are talking about increasing allocation to health, of course, there need to be a different source. The sources have to increase, because if the pie cannot increase, it's going to be difficult. So one is an initiative underway is about establishing health funds on resilience and equity, which can serve as an emergency for emergency situations like pandemics, but also for key gaps where there are health equity gaps. And the idea is to have this funded from a sin tax or excise tax that was recently instituted or implemented in 2020. This is Ethiopia passed a proclamation putting this excise tax on alcohol, tobacco, sugary drinks. So we are just starting to get the revenue from this. So there is negotiation between Ministry of Health and Ministry of Finance to have some percentage of this revenue be allocated for health. Others, like compacts between governments and donors to bring more resources to health in gap areas. For example, we had a huge shortage in the budget needed for family planning commodities. So here the government committed more resources, with donors also matching that resource. And then, of course, when we talk of health financing, a key aspect on efficiency is the strategic purchasing of health services, how we design our health benefits package based on the impact, and then how we deliver provider payment. And mostly has been an input-based system, but we are now reviewing and doing pilots on different purchasing mechanisms like capitation or performance-based financing to ensure that we have more output or impact for the resources that we have. This is just the link is when, in case this is shared, then I guess you can see a little bit more on strategic purchasing for Ethiopia. And the last one, but not least, is the private sector engagement, which should play, especially in the situations we are now, should really play a bigger role in both health and other sectors. So increasingly, although we still have a long way to go, increasingly there's a stronger commitment by government to create conducive policies for the private sector, particularly to expand local pharmaceutical industries, tertiary care, which is very difficult for the government or the public sector to provide, to be more enhanced through the private sector. So creating conducive policies like tax exemptions or tax grace periods and other incentives. And the other is public-private partnership projects, which are still, I mean, there is the first step of having the legislation has already been done, and there are ongoing projects to establish big diagnostic cancer centers with public-private partnership model. But because it was initially envisioned for bigger like infrastructure and other projects and not the social sector, this is still lagging in terms of progress, but with huge potential. And that's an area where we see a lot of potential could be gained. And of course, having a strong coordination between the government or the ministry and the private sector through their federation has been ongoing, because that's where there can be a lot of opportunities of partnership where the private sector can work much hand in hand with the overall ecosystem. And recently we've been increasingly, unfortunately, even though there is still a health workforce shortage, unemployment of health workers is a big challenge because, of course, the capacity, the fiscal space, and so on is limited. So we've been working to enhance entrepreneurship and employment opportunities, to introducing new standards for things like telehealth, home-based care, and office practices, which has really expanded the opportunities for new young graduates to go into the health sector, and including things like social impact bonds for things like menstrual hygiene products, and others are being implemented. But this is an area that requires a much stronger focus and opportunity. So to conclude, I think the time again that we are in is very challenging, but also as I said, I'm very optimistic, and I'm hoping with stronger political commitment and leadership at country and global level, this can be used as an opportunity to really enhance country leadership, to bring change in those gaps that we have, because it is crucial. I think the key message is that country leadership is crucial for the progresses that we need, but also to ensure development assistance, however amount it is, that it is effective. But I think also addressing equity gap that we have globally in many of the, I mean, in public health, but beyond, is not just countries' responsibility, it's also a global responsibility. And transitioning from development assistance should be planned ahead. It should be gradual, it should be strategic, and in partnership, because otherwise it was going to have a lot of disruptions, but it also will cost a lot of lives. And that's what we are unfortunately seeing now, with sudden abrupt disruptions of development assistance. So that partnership as a global community is crucial for us to bridge those equity gaps. But ultimately, enhancing domestic financing through innovative approach and through strong commitment, again, is an opportunity in this challenging time. Thank you so much, and look forward to have a discussion.
Hi, so yeah, we will now open the Q&A session. Okay, so let's start with you.
Hi, thank you so much. I'm Brendan. I used to work at PEPFAR, and yeah, of course, it's a really upsetting time. One of my questions for you is like, yeah, the Trump foreign policy and like the stop work order really shows that like the humanitarian case for global health aid is just thrown out the window. And it's, you know, like in Trump foreign policy, it's more transactional. So I'm curious what you sort of see as the future of like strings attached aid from the US. Like, do you think that could be a possibility in terms of health? Because, and like, what gives you hope? Like, you know, because I feel like the national country leadership, that's been talked about for like decades, and it's really hasn't materialized, or like to the extent that it can fill the vacuum of like US funding. So I'm just curious about those general questions. Thank you.
Yeah, thank you. It is for sure it's not going to be easy. I mean, I'm really hoping some of the things would be reversed, because filling this gap in such a short time would not be possible for any country or even the global community. I, of course, feel hopeful because there's a lot of commitment globally to ensure that all of us are responsible. We are an interconnected world. It's not, I mean, we have learned a lot from the pandemic. We hope we have learned a lot from the pandemic, that we are such a connected community globally, and there is such commitment. So I'm hoping many other partners or countries and private philanthropists will also step up to fill up those gaps. But also this will create a strong push for countries and regions like that. I mean, as a continent, the Africa Union and at country level to really push us to explore different opportunities of the overall increasing revenue, different reforms that could be implemented and have not been implemented strongly, introducing things like I mentioned, health tax, which in many countries have not yet been introduced, which has a potential of reducing different morbidities, mortalities, but also enhancing revenue, the insurance systems. Because if you look at the different interventions that are possible, in some cases they are just tried in few pilots, in some countries not at all attempted. So I'm hoping this kind of shock or push would bring an opportunity of that drive to bring to implement in those. But in any case, this requires time and requires gradual transition. So my hope is that things will come back to work on this collaboratively. Yeah, thank you.
Okay. Thank you. Hi, my name is Gianni. I'm a student in the School of Public Health. I was really interested in what you were talking about regarding health system strengthening, and I was wondering if you've seen kind of an increase in health system strengthening funds via global health security and pandemic preparedness, given that that kind of touches a lot of different parts of the health system. And was also wondering if there are other examples of programs that have been successful in like reaching those their programmatic goals while also having a health system strengthening capacity, kind of like PEPFAR has across the continent.
Yes, absolutely. There is more commitment towards health system strengthening than it was before. In the early days of the Millennium Development Goals, we had huge challenge of HIV, malaria, and a few other diseases that were given more attention and immunization, and rightly so. But progressively, even multilateral funders like the Global Fund, Gavi, all have big components of health system strengthening programs, which are, of course, aligned towards the main focus of the programs. But again, the investments are not just limited to address one problem. If you are investing in cold chain capacity, it would also impact not just for vaccines, but also for pharmaceuticals and other commodities. When you are investing in health workforce, they are not necessarily only addressing those specific diseases and infrastructure the same way. So it has been increasing in investment. But while we are still working on, again, increasing the investment in health systems, we still, of course, need vertical programs, and that is always a balance of the two that's critical. But progressively, it has to, of course, increase towards the horizontal programs. But I think the Global Health 2050 report also outlines a very interesting point on the approach to health system strengthening and universal health coverage, in that we cannot have achieve the impact or the progress we need if we are just doing blanket investments on health systems, unless we are prioritizing also some issues. So it has outlined, based on the different analysis, about 15 priorities, of which are 8 are maternal and child health, and infectious diseases, 7 are NCDs. So it would bring more shift to the amount of resources that are currently allocated to those issues. But if we invest in that approach for the health systems to be able to comprehensively deliver on those priorities, then we can have progress. But there is definitely that kind of approach or focus, including, as you said, PEPFAR, on health systems, which is encouraging.
Hi, thank you very much for your wonderful lecture. My name's Aidan, and I'm wondering whether you can share some transition experience of Ethiopia, and what kind of challenges are you facing, and how did you tackle with those challenges? Thank you.
Yeah, there have been different transitions. I guess you are aware of the PEPFAR cuts that have happened maybe around 5-6 years ago. There were significant resource cuts. Well, for Ethiopia, it was at least significant, because that happened because we moved into the lower prevalence of HIV, which was good in its own. The achievement was good, but it resulted in a significant cut. So we had to again. It was not just during the cut, the significant cut, that some of the preparations were done. As I said earlier, the investments on infrastructure were there. Human resource, it was a big focus to ensure that they are salaried by government, but there were a lot of also workers, particularly like what you call case adherence supporters, and who are not part of the formal civil service, but they were paid by external sources. So what we did in that case was to really have a clear plan by the regions to absorb these employees to their to the public or civil service system. Although it was not easy, but every region gradually did that, so that they continue to give the services that needed to be provided. This was one example I remember. But as I said, it doesn't happen just during that cut. Some of it happens after the fact of the funding cut that prompts those transitions. That's why I'm saying maybe those kinds of challenges will push us to go further, but also some of the principles that we followed also helped in that transition in those regions.
Hi, Dr. Tadesse. FIFA Rahman. I'm former pandemic negotiations consultant for Africa CDC. I want to refer to a ministerial that was held last year in February. And I remember your statement being really good, South Africa's being really good, number being really good. But then some ministers came and it became a little chaotic, if you remember, in that meeting. And some ministers not kind of knowing the technical terms and things like that in the treaty. And I was just kind of wondering, in your role in the Ministerial Leadership Program and of course in other roles, more regionally or continentally even, what is the approach to ensuring that kind of chaos kind of doesn't happen again, and maybe that ministerial leadership is maybe better across the continent?
Thank you. Of course, leadership is really crucial to all what we are talking about. And if we do want to see progress, we need to have the right kind of leadership. But I think the key aspect is not for all leaders to be also technical experts, but it's, of course, they should be aware of what are the priorities. They should be clear on what the priorities are, but also they need to be able to build the right kind of team that can really with the diverse kind of expertise that's needed that can really help them push forward. They should set the vision, set the priority and the strategy, but that all requires a very strong team, but also collaboration across sectors and across key stakeholders and partners. So I think programs like the Ministerial Leadership Program at Harvard and the one that Africa CDC has started play a key role and should play more enhanced role, especially in this time. We may need more things like more programs like that, but there is opportunity. I think the key thing that we want is the commitment, the political commitment, the leadership commitment, and then the expertise coming around them is crucial. You cannot know everything as a leader, and it's not necessary that leaders in the health sector need to be health experts. I mean, it helps if you have a health background, but we have seen very strong leaders from the economic sector in the leading health, as long as they have the right team and they are open and ready to listen, to learn, and drive the ship, I guess.
Thank you. This is Yunus, postdoc researcher at African Studies Center. My question is about Ethiopia has been past very tough times over the last 4 or 5 years due to geopolitical development in the region, Tigray issue and others. How the domestic and regional development has influenced public health program and other public expenditure? Is there any correlation? I mean, how this geopolitical dynamics influence the Ethiopian health program?
Yes, I mean, this has been a challenging time for, globally, but also more so in Ethiopia, because we have all passed through the pandemic, which had its own huge impact, and then different conflicts that do have the economic and social impacts. Of course, the pandemic had its own opportunity in terms of increasing the commitment or the support towards the health sector, because it clearly showed that we need to invest more on health. So that's a time where we had actually increased funding and support from the government, but also from other donors. So the overall health spending had increased. But also we have faced a huge challenge. I mean, with the conflict, we had health facilities which were affected, distracted, and required rebuilding. In that challenging time, we needed more resources. Again, there was a need to rebuild. But I believe it was, so it has affected it, definitely. But there was also a lot of efforts, starting from the COVID pandemic up to the reconstruction, but also other climate crisis issues. We've had flooding, droughts. There was a very strong community mobilization that was being done, which really helped us see more sources that we have never thought of. That's why actually we are pushing for the establishment of Health Equity and Resilience Fund, because this is a sustainable way where we can get other resources which are not traditional. Usually we don't mobilize resources from communities like diaspora communities, even in-country private sector businesses and others who were willing to contribute. We had the mechanism for the pandemic, we had the mechanism for the reconstruction, but once we are over that, we want to continue that for the health sector itself. So that's why we're strongly doing that. But that's when we saw those kinds of collaboration, which helped us at least pass through those challenging times in terms of having the investments. Not enough, for sure, very limited, I mean, quite constrained still resources. So we still have a lot of communities which were impacted through all this crisis. So I'm not saying we had enough, but these are the opportunities also that we had seen and used.
Hi, nice to see you again. My question is actually a good follow-up. I think a lot of the conversation is related to like resource limitation in emerging economies. And your previous talk, you talked a lot about basically pushing healthcare on the forefront of the budget. So I wanted to hear more about the strategies used for that and like the political feasibility in the years to come.
Yeah, I think one specific approach that we have been trying, so it's not necessarily to say health should be in front of everything, but it's saying it should get what it needs to be allocated for. And it's really one key aspect is really the mindset shift we're trying to make, that health, investing in health is an economic investment, not just an expenditure or a social investment only, because it has, and showing clearly with data the return of investment of the different components we're talking about, not just talking in general terms, but if you invest on nutrition, what does it mean for economic development, the return? If you invest the family planning, what does it mean in terms of not just showing, of course, the health impact in terms of reducing morbidity, mortality, but also the economic return that it has. So that has been the key approach that we used to discuss with Ministry of Finance, Parliament, committee members, and others to influence those decisions. So the evidence base, so strengthening evidence base, and those communications has been key, but again, not easy.
Hi, thank you very much for your talk. I wanted to go back to what you said about the absorption of jobs for community health workers into other regions after the PEPFAR cuts. And I'm interested in the concept of brain drain, I guess, in a lot of African nations. This is like an ongoing issue, but how do you see the scale up of health systems strengthening with the scale up of clinical capacity and people, or non-clinical capacity in, it's hard to do those things simultaneously. So do you think that one has to come before the other? Do you think that they can happen simultaneously? And how do you see the scaling up of health systems with the scaling up of capacity in the current context of decreased, resourcing and resourcing limitations?
Yeah. So the approach, I may not have a straight forward answer, but just a case for Ethiopia, we've been investing at kind of at the same time expanding infrastructure, but also expanding health training programs. And actually, at some point, it was called the flooding strategy for health workers, because we had significant shortage of health workforce, and in addition to the brain drain that we had. But with that flooding strategy, of course, progressively, it started to become more than it can be absorbed. Previously, everyone would be assigned through government so it was actually mandatory to serve the government before you are given your license to practice anywhere. Now, it's been about 5-6 years since we stopped that, and everybody can get their license upon graduation because the government cannot hire everyone. So the expansion had continued, but it's not just the infrastructure. As you say, the fiscal space has to also expand. The health center may be there, but cannot hire as much as they want because of their limited budget. So that's why the health financing aspect also comes into play. So you have to look and course correct every time in those strategies. So the past few years now, we have shifted away from the flooding strategy and decrease the intake. For example, if the medical school was taking 300 students per year, now they take 150 only, but trying to focus on the quality of training. So we work a lot with the Ministry of Education in terms of how can we ensure the quality of training is better, introducing standard national exams upon graduation and other interventions. And then at the same time, those other interventions I mentioned for the enhancing employment opportunities. But you have to, so this is all related to it is an implementation science by itself. I mean, you implement, you have to see and then course correct those strategies based on the evidence that's being generated. There is no right answer on how, but I don't think you should be doing one and then after the other. It has to go hand in hand. And then you have to, because all the key pillars of the health system have to be invested and go hand in hand. Otherwise, it's always challenging. A good example I can give you where it was challenging is a few years ago, we decided that the primary care, we have expanded a huge number of primary healthcare centers. So the institutional delivery of women delivering in health facilities has increased, but still the access to C-section was not increased and neonatal mortality was not decreasing. So to avert that, because the number of hospitals is still low, we decided to invest in about 400 health centers to build operation theaters. So ORs, so the OR blocks were constructed in quickly, but then we could not, we did not have enough resources to quickly equip them and then staff them. So now we started to train people who could do the surgery, because the surgeons or OBGYNs we have are very few and cannot go to those primary care centers. So we had to build a program of training GPs to do C-section, because there have been those experiences before, and then of course mobilize resources to get the equipment. So, but it should have been planned when we started the construction. We should have started the training. So I think it's key that those things go hand in hand.
Okay, I think we have time for one more question. Oh yeah, you can have, yeah.
I really appreciate the time and expertise you share with us. I come from a region where a lot of parts of the country are not under formal government control, and development has extra challenges there. That's not just healthcare related, but politics related, geopolitics related, conflicts related. Since Ethiopia has recent history in like Amhara, in Tigray, in Oromia, with parts of the country outside of maybe the formal healthcare system, I just wanted to ask your experience on how do these kinds of work interact with these shifting lines of control, and do you treat areas outside of formal government control in the same way, and what strategies are there to advance health equity everywhere, not just places where there are the formal government controlling the health spaces?
Thank you. That's a really key, important question. Tough one, but I mean, the government, the ministry has a huge responsibility to ensure equitable care everywhere, but it's not always easy, as you mentioned. So in those cases where you don't have presence, but there is a need that humanitarian assistance, healthcare should be provided. The way we have been working is to work with all the development partners and the humanitarian partners through a very strong coordination mechanism. So we've had, so it's not just coordination though, but the key issue is the first comes still government having that leadership role to coordinate all these players, because you have many humanitarian actors, but sometimes you see in those affected places, in one village, there are 4 or so humanitarian actors, but in the others, there is none. So you have to bring everyone together and ensure that all the places are being assisted, and assistance, partners are not duplicating efforts, but giving those services. Additionally, what we've been doing is, though the development partners and humanitarian partners have the resource, like they bring supplies, resources that's needed, but not enough. Some of it has to come from the government. But even if the government cannot go, we decide the commodities that were already allocated for those communities would be delivered through those partners. So to ensure that the HIV medicines, the malaria, and other supplies are getting there through other partners. So again, in some cases, it becomes difficult to make it timely, which had its own challenge, but as much as possible, that was the approach we're trying when the government was not able, but they play a key role in that. But the other last point I want to make is we always discuss about how the development partners should also, the humanitarian and development partners, this nexus between development and humanitarian assistance, because it should not just be addressing the humanitarian issues, but at the same time ensuring some of those are lasting approaches.
Well, thank you very much, Lia, for your time. We have a small gift from the CID team.